Hello, hi everybody. This is Deepak Kisani. I'm a PGY3 R2 radiology resident from Las Vegas, Nevada, Mountain View. Welcome to the talk, Acute Care Management for the Interventionalists. Excited to have everybody. So I'm one of the co-chair along with Dr. Ramiz Rahman, and we have Dr. Khanant Desai and Dr. Vatakancherry who are going to be giving the talk. And this is going to be brief management of acute conditions in the critically ill patients for the interventionalists. And then we'll have some questions from the audience at the end. All right.
Great. Thank you, Kasani, Dr. Kasani. So, kind of introduce how I kind of met Khanant, Dr. Desai. It was through one of his co-residents, I think Peter, was it his name? He was one of the chief residents at the time. We had a kind of a VR chief resident group, and he had told me that you were a UVA fellow at the time, I think, and then we're going to pursue this, and that's how I kind of talked to you and interacted. And can you kind of tell me about kind of your why you went into kind of medicine per se, and then radiology, interventional radiology? What was your kind of thought process behind that?
Yeah, happy to do that. Thanks everyone for having me. My name is Khanant Desai. And thank you so much for those introductions. So basically, I completed my IR training, and now I'm a PGY 7 surgical critical care fellow through the Department of Anesthesiology at Brigham and Women's Hospital. So I'll definitely go into why I'm doing what I'm doing, how I got there, but to answer your question, Dr. V, I always wanted to be a doctor in some respects without titles. I want to be a doctor who treats the patient, treats the disease in every way possible. So not only doing the procedure, but the diagnosis, the management, the follow-up. I want to be that patient's doctor for their particular condition. So that's the guiding principle that I've always wanted. I found IR kind of through medical school. I was always interested in maybe cardiology, critical care. And I found IR and we treat the sickest patients in the hospital. We deal with acute physiology and we fix things. I think that's the coolest part about it. We fix things without opening the patient up. Through 7 years of training, I found my optimal path, and I'm happy to go more into it.
Great. All right. Well, appreciate it. And I think it's a very exciting time. I know you gave the keynote lecture at our second annual West Coast Vascular Interventional Surgical Symposium, and it was well received by a lot of people who have a great deal of interest in this. And hopefully this will be a future trend for many of these medical students and trainees that are joining our group. And we can't underemphasize the importance of getting ICU training early. And certainly if you're going into interventional and you're a medical student, your fourth, you should definitely do at least one unit rotation. All right, without further ado, I want you to get your talk started. And please keep the Q&A active, and we'll try to answer whatever questions we can in a timely fashion. All right, Dr. Desai, go ahead.
Thanks so much, Dr. V. So, I'll elaborate a little bit on your question. So number one, the modern practice of interventional radiology is a lot more similar to general surgery, interventional cardiology, vascular surgery than it is diagnostic radiology. We don't just image, we don't perform imaging examinations and diagnose patients. We use expertise in a variety of fields, anatomy, physiology, pathology, to diagnose disease, and then we utilize a knowledge of disease process to determine the best management for the patient, and then we treat the patient. And this is extremely important. If we ignore this truth about the modern practice of IR and we don't take responsibility for managing our own patients, as well as the surgeons and internists do, we actually deserve to lose those patients. No specialty, in my opinion, is inherently entitled to a specific patient population or procedure. You have to earn the right to take care of these patients. And if you don't earn that right, then you will be told what to do by other specialties. And unfortunately, many of you who are already in training at different programs throughout the country might have already seen this, where, for example, urology is telling us to put in a PCN, or trauma surgery is telling us to embolize something. In my opinion, this is a shame because an IR operating at full potential has absolutely unparalleled skill in safely, effectively, and efficiently treating disease. So where are we right now? This has been talked about probably for the last 10, 20 years. PAD patients, right? Let's just take an example of someone we treat and used to treat quite a lot of. A PAD patient right now at many places goes into the ED, goes into primary care. They get referred to cardiology through vascular medicine or vascular surgery. And then interventional cardiology or the surgeons are the ones doing the procedure. And if they can't fix something that's going on or it's just too complex for them, they pass it on to IR. So you say, well, IR is always inventing new procedures. What about, interventional oncology, venous disease? We kind of own those things, right? Well, in a lot of places, with venous disease, this is also happening. We're getting put to the side by interventional cardiology or vascular surgery. This is where we need to be. We need to be directly plugged into the patient. And if that's not the case, then we need to be directly plugged into the ED or primary care. So, this is a question you have to ask yourself. Are you on the road to become one of the most highly trained physicians on the planet just to be treated like a technician, like Charles' daughter was when he did the first ever angioplasty in history? Visualize, but do not try to fix. Do what's right by your patients, master the management of their disease, not just the procedure. So hopefully I've kind of convinced you that this is the right way to practice IR. If you want to take care of patients, there's really two components to it, right? There's longitudinal disease management. This is something that Dr. V, for example, is so good at, has given so many talks on the management of vascular disease, PAD, long-term. But you also need to be good at taking care of acute patients. So those patients that are crashing in the hospital, you get consulted on. You need to be able to manage procedural emergencies, inpatient admission, and management, consultation. I think that every IR should be able to manage all of these conditions, or at least know what the management is and what it should be moving forward in the patient's care. This is old IR training. It's 3 pillars, but patient care was kind of always pushed to the side. This is what it should be. And this is my goal of what I would love to make the new training paradigm reflect. So with that, actually, I'll pause. And if anyone has any questions, points of discussion, I'm happy to talk about that, or happy to jump into a couple of cases. Critical care is impossible to teach in the span of 1 hour. And so Dr. V and I kind of decided to have a couple scenarios. Number 1 is hemorrhage, and number 2 is respiratory failure, which I'll kind of go through my algorithm as a critical care specialist for, and also talk to you guys about where IR fits into those.
Any questions from the panel or anybody about kind of what we've talked about or kind of spread on the chat? Brian or Deepak or Devin?
Yeah, it looks like here we have a question from Ashwin. It says, how do we change this culture and what is the initial step?
Yeah, I think that's a great point. That's almost the fundamental question, right? So it all goes back to that first point. IR was born out of diagnostic radiology, and our training paradigm matches diagnostic radiology. We spend so much time learning diagnostics. So much time spent learning mammo, NUPS, all that stuff. But how much time do you actually spend learning how to take care of shock, respiratory failure, et cetera? I think this starts on a curriculum level. I think as a medical student, and Dr. V will speak to this, but as a medical student, you need to do as much ICU and consult rotations as you can. Become comfortable taking care of not just the bleeding patient, but be comfortable with transfusion medicine. I mean, that's the whole point of it. So starts in your 4th year as a medical student. As an intern, of course, everyone now has to do a very intense surgical intern year, which is great. And then find ways in those 3 years of diagnostic training to incorporate ICU training into that. Of course, not everyone needs to do a critical care fellowship like I am. I mean, I don't expect everyone to do that, but I think at the end of this year, I feel so great about taking care of these patients. I mean, I'm excited to do it. I'm excited to take care of a crashing pulmonary embolism patient who's developing right heart failure, and I need to put in VA ECMO or an oxy RVAD device on top of doing the intervention. So those are just kind of high-level ways to fix training.
There's one more
Great, thank
question.
you. Yeah,
One more question. I think it overlaps. So what can medical student leadership do to facilitate the paradigm shift from the generational standpoint?
Yeah, I mean, it's the concept of managing up, right? Of course, ideally, we would have, top-down change with the IR curriculum. We would have an IR in-service exam. We'd have a separate board examination that incorporates a lot more patient care aspects of it. The ABSITE exam, for example, 25% of that exam, the surgery and training exam, is all about patient care. It has nothing to do with doing surgeries. So that would be the ideal thing. But as a medical student, give lectures, ask your attendings to go upstairs and do rounds. And if they're not going to do it, then you yourself make it a point to go up there to the ICU while they're having rounds and say, hey, we're consulted on this patient. This is my medical opinion of what to do. For example, portal hypertension. We think that TIPS is better than an RTO for this patient. And by the way, you should have this patient on vasopressin to help their splanchnic circulation out. That goes such a long way, I can't even describe. So start there, take ownership of your patients.
Dr. Desai, we have another question from Subhash in the chat. He asks, do most IR programs offer flexibility to do ICU electives during training? Is this a common option? I guess what options have you seen throughout your training?
Yeah, so my background is I actually did ESIR. And so I did 3 years of diagnostic training and then a full year of just IR and basically whatever I wanted to do. So in that ESIR year, I actually made it a point to, I did a CCU month and I did a SICU month as well. And then of course, in my intern year, I did a bunch of ICU months as well. So, I think going to your program director and advocating for this will go a long way. Because in the end, the program directors, the IR program directors, I mean, yes, they do have to work with the constraints of being part of a diagnostic program, but at the same time, there is some flexibility there. And if they hear from you that, you want to keep up with their clinical skills and not go 3 years without taking care of a patient under your care, I think they will be responsive to that.
Great. I think we should continue on this scenario. We can keep the questions going in the chat box. I'll try to answer some of them, but let's go, for the interest of time, let's go on to your scenarios.
Awesome. Let's do it. All right. So first case, if you practice any IR at all, you're familiar with the scenario. Something is bleeding somewhere in the hospital and, IR gets called right away. Some people might find that a bit of a pain. You get these consults and they haven't really done a lot of a workup. But to me, this is a huge opportunity. I think IR is in a great position to own hemorrhage in the hospital, be right on par with trauma surgery and managing hemorrhage. So this is a sample case, 63-year-old male with a history of AFib on Eliquis, involved in a car accident. Multiple fractured bones, obtunded, intubated in the field for airway protection. They're hypotensive in the field despite IV fluids. They have an open book pelvic fracture and a CTA is performed. And that shows injury of this very classic vessel. It's the corona mortis vessel, which is communication between the inferior epigastric artery and the internal iliac artery. And so you get called. What do you do? So hemorrhage, of course, and trauma specifically, traumatic hemorrhage is one of the biggest issues in our country. 50,000 deaths a year associated with traumatic hemorrhage, in addition to all these other things, aneurysm, postpartum hemorrhage, things, by the way, that we are very intricately involved in as well. So in order to treat hemorrhage, you need to know the pathophysiology of hemorrhage. So on a very basic level, we have 5 liters of blood in our bodies. 2 liters of that is red blood cells, 3 liters of that is plasma. And if we start losing that, we go through these 4 stages of shock, right? Which everyone learns in medical school. You're initially compensated by fluid shifts, then you move to systemic vasoconstriction to maintain your blood pressure. Then you become decompensated and you go into hemorrhagic shock. So that means cold extremities, peripheral vasoconstriction, oliguria, and end organ ischemia. And then finally, you go into severe hemorrhagic shock. You have hypotension, you have tachycardia, and you become confused, you have multi-organ ischemia. So when you see this, when you get this consult, I don't want you to start thinking first about the procedure. What I want everyone to start thinking about is shock, right? How do I manage this patient's shock? So what is shock? It's tissue hypoxia from a very fundamental level. Tissue hypoxia happens because of inadequate O2 delivery or impaired utilization. So what's the pathophysiology of hemorrhagic shock? Well, that's very important to keep in mind. It's loss of blood, which leads to a loss of preload. That loss of preload is going to cause a decrease in your stroke volume, which then decreases your cardiac output. And a decrease in your cardiac output is going to then lead to this decrease in O2 delivery to your tissues, and also a decrease in your MAP, because MAP is cardiac output times your systemic vascular resistance. Your body sees this decrease in O2 delivery. It pulls oxygen from your hemoglobin molecules. And then finally, it hits a point called your anaerobic threshold right here, where it can't pull any more oxygen off the hemoglobin, and you start developing tissue hypoxia. You go into shock. So knowing that pathophysiology, then you know what the fix is, right? You want to bump up your oxygen delivery. And in order to do that, you actually have to increase your preload. You need to give blood product. So hemorrhage is actually, and hemorrhagic shock is a multifactorial process. There's kind of this bloody vicious cycle that's involved, where you have hypothermia, coagulopathy, and acidosis. And those things feed on each other and cause worsening hemorrhage in a horrible cycle. So what do you do to treat it? When you get these consults, this is not just pre-hospital management. This is pre-hemostasis management, right? So when you go see this patient in the ED, you need to make sure all these things are happening. You got to assess the severity of the shock. You have to identify and tamponade obvious sites of bleeding. So tourniquet, pelvic binder, hemostatic dressing, warm the patient, limit the fluids, and then do your diagnostic workup, radiographs, a FAST, a bedside ultrasound, CT and CTA. The principle of hemorrhagic shock treatment, of course, is something called damage controlled resuscitation. So that's where you repay your oxygen debt. There's multiple tenets to this. So restoring your oxygen delivery, repleting your coagulation factors, correcting your electrolytes, correcting acidemia, warming the patient, and then, of course, achieving source control, which is where we come in from a procedural standpoint. So, you'll get these calls all the time. Patient's hemoglobin is low and they just got into a trauma. You need to be intelligent enough to know that in acute hemorrhage, you cannot just rely on the hemoglobin level, because hemoglobin only decreases when your whole blood losses are replaced by pure fluid, right? So when you bleed whole blood. And so initially, you can't just rely on that hemoglobin level. So finally, we get to this, the core component of treating hemorrhage, which is giving blood, right? So how do you give the blood? Access is the most important thing. And this is something, again, you learn in med school, basic physics. The catheter that you use should ideally be wide and it should be short. This is kind of a modified form of the V equals IR equation that we learn in physics. So what that means is a short, fat, peripheral IV catheter is actually better than the smallest port in a central. These are optimal accesses for your hemorrhagic resuscitation. These are basically just sheaths that we use in IR all the time. You may have heard this term MAC. It's a multi-lumen access catheter. Again, it's a short, fat sheath that can go in the IJ, it can go in the femoral vein, around 8 or 9 French, about 10 or 11 centimeters. So your initial management really revolves around, restoring the MAP. If you don't have blood immediately available, then you should give isotonic crystalloid, something like lactated ringers or normal saline. And you want to limit that to less than 3 liters in the first 6 hours, because of course you have a danger of diluting platelets and your coagulation factors. You want to draw off your labs. And when I say labs, you want to get a type and screen to get your blood type and recipient antibodies. That's the quickest thing you can get. If you have time, you have about 45 minutes or so, you should get a cross match as well. And that'll actually compare specific donor units to the actual patient's blood. You want to get your coags, so CBC, INR, PTT, fibrinogen, and a TEG, which I'll talk about in a little bit. Electrolytes, and of course, get a pH with a VBG or an ABG. If the patient is bleeding to the point of hemorrhagic shock, of course, there's a lot of controversy as to what consists massive transfusion protocol or what that actually means. But generally, if the patient is bleeding enough to be hypotensive or you are concerned that the bleeding is active, go ahead and activate this massive transfusion protocol. Every hospital has their own protocol for this. But the data shows that a 1-to-1-to-1 ratio of plasma to platelets to PRBC is the optimal resuscitation ratio. There's two trials, the PROMPT and the PROPER trials. PROMPT showed it's a prospective trial that showed improved early survival with a balanced rather than a PRBC heavy transfusion protocol. And PROPER showed increased hemostasis and lower mortality from bleeding in 1-to-1-to-1 versus 1-to-1-to-2 transfusion. So the most recent guidelines from our trauma surgery colleagues in 2017 have the highest level of evidence for this 1-to-1-to-1 transfusion. You should have some idea of what that means. PRBC is about 350 ml in each unit, and that increases your hemoglobin by about 1 gram per deciliter. Platelets are pooled, and so actually in most hospitals, a 6-pack of platelets is one kind of pool of platelets. That's about 300 ml, and that should bump your platelets by about 5,000 to 7,000. And then FFP is frozen, of course. It can stay up to 3 years, and that's about 200 ml volume. After you've given the blood, there's a little bit less data for these kind of supplements, but they're very frequently given. So cryoprecipitate is used to replete your coagulation factors in a much more concentrated form than fresh frozen plasma. It's been studied in traumatic and obstetric hemorrhage, again, two things that we see very often. It comes in a pool of 10 units. So that's about 150 to 200 ml. And that raises your fibrinogen by about 50 to 100 per pool. TXA is another great option. So that's actually an inhibitor of fibrinolysis. It inhibits plasminogen to plasmin conversion. Like I mentioned in that kind of vicious cycle of hemorrhage, hyperfibrinolysis is a state that many people in severe hemorrhage go into. This has been studied in trauma through the CRASH-2 trial and also in postpartum hemorrhage through the WOMEN trial, as well as perioperative hemorrhage. So in order to give this, you want to give 1 gram IV immediately, and then you want to give an infusion of 1 gram over the next 24 hours. And then DDAVP. So this is something that's frequently used to counteract platelet dysfunction from uremia or antiplatelet therapy. You can give about 0.3 mics per kg IV up to a total of 21 mics. The dangers with this, of course, are that DDAVP is an EDH, right? So it prevents free water excretion and can give you hyponatremia and can also give you some hypotension, so watch out for that. This is a very exciting technology, thromboelastography, or the TEG. Basically, it's a device that creates a clot, and then it measures the clot formation and clot breakdown. And the utility of this is that very quickly, you can find out what process in coagulation is impaired. And so you see all these variables, R, K, alpha angle, MA, and lysis 30% time. This machine will give you literally a readout of these variables, and then based on these variables, it tells you exactly what factors or supplements to transfuse. So for example, in someone who has a factor deficiency, right? You're going to get a prolonged R time, and then you can go over to this table and say, okay, I have a prolonged R time. I need to give plasma and PRBCs. This is something that does not have a ton of data behind it. And so you will actually look very impressive to your critical care and trauma surgery colleagues if you, and anesthesia colleagues, by the way, if this patient is in your room for a procedure and you say, okay, let me know what the TEG is, and based on the TEG, I want to transfuse platelets or plasma or TXA. And then, of course, everyone these days, it has AFib, they have a mechanical valve, they're going to be anticoagulated on top of being in a trauma. And so you really need to be at least, familiar with how to reverse that anticoagulation. So warfarin, of course, the mainstay is giving vitamin K IV right away. It takes about 6 to 12 hours for that vitamin K to work. And so in the meantime, you want to give PCC, which is Kcentra. And if you don't have that available at your hospital, you can give 4 units of fresh frozen plasma. If someone's on a heparin drip or if they're on Lovenox, the reversal is protamine. And you might be familiar with the fact that protamine has a danger of an anaphylactoid reaction. So you can get hypotensive bradycardic. And so our anesthesia colleagues frequently will give a test dose of 5 milligrams to see if the patient can tolerate this. The duration of this of protamine is about 2 hours. And so keep in mind that if someone's on Lovenox, you may need to give multiple doses of PCC. The novel anticoagulants, very useful. Many of them are oral. At the same time, the danger, of course, is that there is no specific reversal agent for many of them. Pradaxa is dabigatran. That's the one agent that actually does have a specific monoclonal antibody reversal agent. So you want to be familiar with that. Very simple. You give 5 milligrams IV of Praxbine to reverse this factor. If they happen to be on Eliquis, like our patient in the case, or Xarelto, you can still give Kcentra. And that will, again, replete your vitamin K-dependent clotting factors. Importantly, PCC also has a small amount of heparin in it. And so if they do have a history of HIT, they cannot get PCC. And you might want to give some fresh frozen plasma instead. If you're ever in the unfortunate situation of needing to reverse TPA, for example, if you're lysing someone for a clot busting procedure, but you've given too much, you can give this cocktail of TXA, cryoprecipitate, and FFP, although keep in mind there really isn't a whole lot of data for this. Platelets are something that are controversial and don't have a lot of data behind them for. But if someone is on an antiplatelet agent, so Plavix, aspirin, you can give them DDAVP, you can give them TXA, and you want to target a slightly higher fibrinogen than normal, so something like 150 to 200. There is a patch trial that was done, and that's an RCT studying platelet transfusion in patients taking aspirin. And importantly, it showed no benefit to transfusing platelets. So this is not something you're typically going to do, but theoretically, if you were to do it, the optimal patient would be someone who's taking a permanent inhibitor with a short half-life. So something like aspirin, for example. So you've reversed their coagulopathy, you've repleted their coagulation factors, you've given them tons of blood through massive transfusion. You have to keep an eye on their calcium levels and their pH at this point, because calcium is important in the initial steps of the coagulation cascade. And all these blood products that you're giving them actually have citrate in them. And citrate, when given in a large volume in a short amount of time, will accumulate in your blood and will actually chelate this calcium, causing worsening hypercoagulability. And so you want to measure your ionized calcium levels at bedside, and you want to replete with either calcium chloride or calcium gluconate. A low pH acidosis, if you remember that vicious cycle, that's one of the things in the vicious cycle. pH less than 7.2 can also interfere with calcium binding, causing worsening hypercoagulability. So in order to fix this, if they're intubated, you want to use that vent to your benefit. You want to blow off that acid by increasing their respiratory rate or increasing their tidal volume. You also want to give bicarb and fix their lactic acidosis. Warming the patient is crucial. Hypothermia impairs your clotting factors. And so use your warm fluid, use your blankets, use your bear hugger, et cetera. So that's just general fixing hemorrhage, right? But there's, of course, etiology-specific hemorrhage. So a variceal hemorrhage is very different than a postpartum hemorrhage, which is different than hemoptysis. So you want to know generally what to do to treat these specific etiologies. And also, I want to show you guys, IR is involved in almost every single one of these etiologies of hemorrhage. That's why we are called when anyone in the hospital bleeds, right? We can do TIPS, we can do duodenal artery embolization. We can do bronchial artery embolization. And then, of course, once you've achieved hemostasis, you want to know what your endpoints of resuscitation are, right? You don't want to just do your procedure, fix the bleed, and then walk away to never see that patient again. You want to know when they are done bleeding and when you can stop resuscitating. And this is where a knowledge of hemodynamics and shock becomes so important. Like I mentioned, in hemorrhagic shock, you're hypovolemic, right? Your cardiac output is down, your O2 delivery is down. And so in order to measure if you fix that, you want to take a look at your map, right? You want to take a look at your urine output greater than 0.5 mils per kg per hour. You want to take a look at your measurements of intravascular fluid level. So things like stroke volume variation, pulse pressure variation, those are a little complicated. I can't get into it right now for time. But again, that coupled with doing a bedside echo are crucial in knowing whether the patient is still volume down or is now euvolemic. You want to look at your measures of tissue oxygenation. So take a look at your mixed venous O2 level. You want that to be greater than 70%. And that tells you that your body is delivering enough O2 to the point where it's not having to pull a ton of oxygen off of that hemoglobin. And then, of course, like to look at your coag factors, your platelets should be greater than 50. Your INR should be greater than less than 1.5. And your PTT should be less than 1.5, the control level. And of course, your TEG is crucial in assessing this. All right, so I'm going to pause there. We can move on to the next case, or we can discuss that a little bit. Dr. V, if you have any input into.
No, I mean, I think you brought it clearly. I tell trainees there's 3 things you should know really well as a vascular interventional physician: bleeding, clotting, and sepsis. You're going to see a slew of these patients. You need to be very comfortable managing. It's not uncommon that a patient will come down postpartum hemorrhage and they haven't checked the fibrinogen. And the fibrinogen, the last one I did was 60. I'm like, let's get the cryo, right? So these things are invaluable. So it doesn't matter if you plug the bleeding. The patient's going to go into DIC if you can't navigate these things. So feel comfortable with Listrida, these different case centra, they rapidly work within an hour. I could give tons of FFP and you still won't get to 1.7. It's volume and it takes time. Whereas case centra, pretty rapid. Within an hour, I can get their INR to normalized and the bleeding stopping, and without my intervention. So quite frankly, honestly, a lot of my intervention is pharmaceutical, and my intervention that I quote unquote do is almost homeopathic. So your benefit to the patients is knowing bleeding, clotting, and sepsis, and how to navigate it from a hemodynamic standpoint and a pharmacologic standpoint. So I think these key pearls are very quintessential. I know Karthik's on the line and he's done a lot of ICU and kind of covered the COVID unit. Do you have anything to add, Kansagar? I don't know if you're free to say anything. If not, we can continue. I know you've been on the chat. All right, I think we can either continue on or go to kind of the, additional either case or go to your hypoxia thing.
Awesome. Yeah. And actually one point I do want to make, you might be thinking to yourself, hey, why do I need to know this stuff to the level of a critical care physician? Well, something you brought up reminded me, we treat variceal hemorrhage all the time. Those patients are cirrhotic, and you need to know your physiology well enough to know that you can't measure fibrinogen, you can't really measure INR in a cirrhotic patient because it's not going to be reliable. And so you need to know your patient's cirrhotic. You need to know what to look for in a bleeding cirrhotic patient in order to treat them. So you're targeting fibrinogen levels. And, these patients are going to be in a state of low-level DIC at all times. And so you need to get a TEG optimally in order to treat their specific hemorrhage etiology.
A couple of quick questions that came up real quick, and one's really good. Beyond having the knowledge you need to own the disease, how do we change them? Sometimes deeply embedded perception referring doctors see the interventionalists as proceduralists. Yeah, that'll be there. So what you have to do is you document your consult note exactly these comments, right? And they will start to use that. Like I saw a patient recently for filter from neurosurgery. I'm like, hey, the patient has submassive features. Let's get a trope, let's get a BNP, let's get a lactate. We need a CTPA because he's hypoxic, he's on 4 liters O2 rising demand, and he's worrisome to me for, someone with the submassive features, even though he's normal intensive. He's a mildly tachycardic, 100 PESI, a little bit elevated. I got the CTP. I did my own bedside echo, shows RV was dilated, put it out on there. I called the intensivist, or the hospitalist. I'm like, we should probably put him in the ICU. He can't get anticoagulated. Put the filter in, put all that in there. They took that to heart, and he did a CTP at RV-LV ratio was enlarged, and it gave him some time to be observed. Owning the trials, including iCopper, Pythos, PREPIC 1 and 2, and putting that in your documentation, in your clinic, in your consult note, again, all add value, where now your thing is not, oh, can you filter or not, or just do it, to adding value where you change the prognosis and natural history of the patient's survival curve. That's how you do it. Time and time again, own the disease, own the trials. And then any good resource in addition to marine learning topics, I used MCRIT and palmcrit.org. They had some pretty good podcasts. So I learned a lot from just listening to those podcasts. There's a lot of ICU podcasts on. Dr. Desai, any other kind of quick things that trainees can do? There's a ICU service line has a ICU series that's on the RFS website as well. Anything else you can suggest?
Yeah, I was just going to give a quick plug for that. I mean, I think that incorporates chapters from the ICU book. I love using, actually, you mentioned PalmCrit. They're a fantastic resource, and they actually have something called the Internet Book of Critical Care, which sounds a little bit low rent, but it is a phenomenal source. And I've actually pulled a lot of my slides from that. And so between their podcast and between the ICU book, you're going to have everything you need to build the foundations for practicing this way.
And then Consagra brought up One Page ICU, which is actually pretty darn good as well.
Yep.
I've used that quite a bit. All right, let's keep on going in the interest of time, but great questions. Keep the chat going, please.
Awesome. So our next case here, this is something I've encountered in my short time in training multiple times. You have a patient on your procedure table, and you're doing a 2-3 hour case, and all of a sudden the nurse tells you, hey, patient's desatting and they're looking a little blue. And so, what do you do? You're the doc in the room. What do you do? And so this is a case, 55-year-old female, history of smoking, COPD, OSA on CPAP, heart failure with reduced ejection fraction, developed severe right lower extremity pain and swelling after a flight from London to Boston. Of course, the physical exam shows asymmetric swelling of the right lower extremity, and ultrasound shows a DVT. So the patient develops dyspnea and desaturates further, and you get a CTPA, and that shows a saddle pulmonary embolism. So I'm not going to talk about the treatment of RV failure and PE, although I would love to. That's its own topic, which hopefully we can bring to you soon. But I do want to talk about respiratory failure and respiratory physiology, because, again, crucial to know. So I want you to keep this in mind. Anytime someone desats, anytime one of your patients desats, you need to know where the problem is, right? And so me and you breathing, the air needs to get from the atmosphere into your blood. The oxygen needs to get from the atmosphere into your blood. And so you have to know what is called the alveolar gas equation, right? So respiratory failure is failure of your respiratory system to oxygenate your blood, which is your PaO2, your P little aO2, which is the amount of blood in your bloodstream. There's really 4 main etiologies, right? The air can't get from the outside into your blood, which is, or into your alveoli, which is a mechanical obstruction. Your FiO2 is low, which is, unless you're on Mount Everest, is not really going to be an issue. Your PaCO2 is high, which means that you're not blowing off your carbon dioxide and you're hypoventilating. Or your alveolar arterial gradient of O2 is elevated, which means that your gas exchange is impaired. And that, of course, is your conditions of shunt, VQ mismatch, and diffusion defects. So anytime you have a patient like this is kind of a good algorithm to go down. Number one, you get a blood gas, and if their carbon dioxide is elevated in their blood, it means they're hypoventilating. At that point, they're either just hypoventilating, which means that they're not breathing enough, they're breathing too slow, they're not breathing they're not taking in big enough of a breath to blow off that CO2, or their AA gradient is increased. So if their AA gradient is increased, then you want to give them supplemental oxygen. And if that desaturation improves with the supplemental oxygen, it tells you that you have a VQ mismatch. Things like alveolar disease, asthma, COPD, ILD. However, if that does not improve with supplemental O2, then you got to be concerned for a shunt, which is blood that is flows from the right side to the left side of the circulation without getting oxygenated. So things like complete atelectasis of a lobe of your lung, an intraalveolar filling defect, things like pulmonary edema, an intracardiac shunt. So this is kind of the general algorithm you should go down. This is kind of a nice illustration again of the different causes of hypoxemia. So a normal AA gradient that corrects with O2, you're thinking of hypoventilation. An increased AA gradient that does correct with supplemental O2, you're thinking of diffusion and VQ mismatch. And of course, if it doesn't correct, then you're thinking of a shunt. So how do you diagnose this? The first things that you get when someone's desatting is going to be get a pulse ox on them and draw off an ABG. Why do we do those things? So it goes back to your equation for the O2 content of your blood. It is heavily reliant on blood that is bound to hemoglobin and much less reliant on blood and oxygen that is dissolved in the blood. Those two things are intricately connected through this curve, the oxyhemoglobin dissociation curve, which you learn in med school. So why do you get one versus the other? Well, ABG will tell you the oxygenation status, but it'll also tell you the pH. It'll tell you the AA gradient, and it'll also tell you the PaCO2. So basically, it'll tell you whether there's an oxygenation defect, and it'll tell you whether there's hypoventilation and hypercarbia. However, your pulse ox is easy to get, and it is actually a more accurate representation of the oxygen that is in your blood, thanks to this equation here. And so you use those two things in conjunction with each other. Hypoxemia is defined as a PaO2 less than 60, and hypercarbia is a PaCO2 greater than 50 with a pH less than 7.4. Why is that important? Because you'll get your COPD patients who have a very elevated PaCO2 at baseline, 60, 70, but their pH is normal. And that's because over time they've compensated, right? And so you don't need to panic at that point if the pH is 7.4, but the PaCO2 is 60. All right, so this is where you
real quick, kind of. So it's interesting about this PaO2 and SaO2. You can see that rapid drop after it gets at kind of that 90% saturation. So we had a case where we were doing a Berto, and it was kind of injecting gel foam, and the patient's SaO2 was maintained, but what we didn't know is the nurse was titrating up the oxygen. So each liter of O2 is around 4%. So if your FiO2 increases, you can maintain your kind of your saturation. So it can be tricky. So sometimes now I drop the O2 down to room air or 0 when I'm worried about potential, embolization to the lungs. So it's just an important concept that came to reality. And so we had to put this patient on high flow O2 after the intervention. He recovered, but it's just something to be cognizant of. But yeah, very important curve, I think, here.
Yeah, great point. So you have someone who's desatting on your table. Number one, you need to decide, does this patient need to get intubated? And so who gets a tube? If your airway patency is threatened, or you have poor airway protection due to mental status. So kind of the key phrase is GCS less than 8, intubate. If your oxygenation and ventilation are impaired and they are refractory to supplemental O2 or BiPAP, and then if your anticipated clinical course requires intubation, right? So if you have worsening shock, your O2 requirements are going to go up, and your lungs are not going to be able to keep up with that O2 requirement, and your shock will worsen. And so you want to help that patient out by intubating them at times. And then this is an interesting one, head, neck, chest trauma. In fellowship, we actually had a patient who we were doing a thyroid gland ablation on, and they developed a hematoma in the neck, right? So they were fine. They didn't have really any comorbidities. They were satting fine, but they had this rapidly enlarging hematoma, possibly from an arterial bleed. That patient, while they may be doing fine right now, 5 minutes from now, they may not have an airway, period. And so in those kind of cases, you want to have a low threshold to intubate those patients. So emergent airway control, right? This year, when I was learning how to intubate patients, my anesthesia attendings would tell me, your most important job might not actually be learning how to intubate and paralyze and induce someone. Your most important job might be learning how to properly bag a patient until help arrives. So you want to ensure a patent airway through your head tilt, jaw thrust maneuvers. You want to insert an oral or nasal airway. Those things can be lifesavers. So up top, you want to measure the nasal trumpet from the nares to the tip of the earlobe, and the oral airway from the lips to the angle of the jaw. And then you want to suction the patient. Your nurses will have this available for you. And then, of course, you want to do a manual bag valve mask. And the most important part of this is you see here the patient or the provider is pulling this patient's jaw into the mask with their pinky and middle fingers, right? And I can't tell you how crucial that is, because you need a good seal with this bag mask to actually be able to oxygenate and ventilate these patients. When you're doing that, you want to order an ABG, get a chest x-ray, and then of course, call for help, right? You've done everything you can at this point, short of intubating the patient. At this point, call a code, call your anesthesia friends. So if the patient does not really need to be emergently intubated, you have all these things to help you out, right? All these great tools. So you have your nasal cannula, you have your high flow nasal cannula, you have a non-rebreather mask, you have your face mask, and then BiPAP and CPAP over here. You should have a general feel for this table. You need to know what these devices can provide you in terms of oxygenation. So your nasal cannula can give you up to 6 liters of flow, up to 44% FiO2. And as Dr. V said, initially you start at 20% FiO2, and each liter of oxygen that you add adds 4% of FiO2 up to 44%. You can work yourself up with a simple mask, a Veni mask, and then my favorite is kind of a non-rebreather for the floor patient that's just not doing well but doesn't really need to be intubated. That can give you actually up to 100% FiO2, but it's a lot of oxygen flow. They need to be able to tolerate it. Then you move yourself up to non-invasive positive pressure ventilation. So your high flow nasal cannula at the highest setting can actually give you some PEEP, and it's very useful. And then of course, CPAP and BiPAP. BiPAP is bi-level, meaning there's a constant inspiratory flow and an expiratory flow. These are very good in certain situations, but the patient has to be conscious, cooperative, have a patent airway. Why is that? Because if they become obtunded and they vomit, you are going to force all that vomit down their airway, which is very bad. So CPAP is great for cardiogenic pulmonary edema. It's good for oxygenation and it lowers your preload, but doesn't affect your ventilation. BiPAP is fantastic for COPD exacerbation, for hypercarbic respiratory failure, for staving off intubation. It's only good for a few hours. This is not an endpoint therapy, right? If they fail BiPAP, they're going to get intubated, but it can be very useful in staving that off. So those are my cases. If you guys have any questions, happy to talk about that. Otherwise, with the remaining time, I'm happy to kind of discuss, why we think ICU is so important. I can talk about my pathway and how I got there. Totally up to you guys.
Oh, great. I mean, great discussion. And it points to the importance of ICU medical management in our patient population. So really key. So let's talk about a little bit about kind of how you're going to utilize this knowledge that you acquired to kind of enhance your future residents training at your program. What's your plans of action? I'll tell you kind of what we've incorporated and where we're to continue transition.
Yeah, for sure. So, number one, in terms of my practice, my practice will actually involve both IR and ICU. So I'm going to be working both as an intensivist for about 10% of my time and 90% of the time doing IR. And I absolutely am going to be rounding on my patients. I'm going to be using my ICU knowledge really to admit more and more complex patients ideally, right? So the way the surgical ICU is set up at our hospital, the intensivists are really kind of consultants. Even though they act like the primary team, the surgeons are actually still the primary owners of those patients, even in the ICU. And I think I would love to practice in that pathway. I mean, a really sick TIPS patient, a really sick portal hypertension patient, someone who's bleeding, even a cholecystitis patient who I put a chole tube into who develops septic shock, I want to be the primary on that patient. And I don't see why we can't do that. And of course, that means teaching my trainees who take care of these patients the very fundamentals of ICU care. This is, in the end, this is what it's about. Why is ICU important for IR? Through ICU skills and patient management skills, you learn the fundamental building blocks of taking care of that massive PE patient, of that variceal hemorrhage patient, of the urosepsis patient. In order to take care of those patients, you need to know respiratory failure, septic shock, renal failure, things like that. And so those are kind of a big picture view of how I see myself practicing. And I hope, all you that are listening to this also feel that you can and you're allowed to practice that way out when you're attending as well.
And, a couple of things that I've noticed in our practice just by having these kind of skill set is we have levofed in our lab, we have Cleviprex or Clevipid in our Pyxis. So in the bleeding septic or potentially bleeding or septic patients, we're able to start it pretty quickly. So that's been pretty helpful in ameliorating some code situations. And then the ability to titrate up, the non-invasive ventilation, whether it be calling for BiPAP or, albuterol nebs, Jaltos, Chintold, and Ambubag until they kind of wake up, has been also valuable for preventing a PE arrest. So these little things really make a huge impact in outcomes, and something I didn't realize before I started learning some of this stuff through my trainees. So in our residency, our trainees do, we advocate them doing MS4 1 month, PGY 1 unit month, PGY 2 ICU weekends and nights, PGY 3 a month of CCU, PGY 5 MICU and CCU. So by the end of it, they get pretty comfortable with the manage these patients and are handling these more sick patients on the floor, in our suites, etc.
There's a quick question from the audience. The question is, how do you recommend other VIRs make a case to be accepted into an ICU fellowship, since this is not a typical pathway?
Yeah, great question. So the way I did it is I did my SICU rotation, which is required for all of you as part of your training. And I just approached the director of the SICU. Of course, I was engaged. I did a good job when I was on that rotation, but I approached the director of the SICU and I said, look, this is the way I think IR needs to be practiced in the future. And I would love to do this 1-year fellowship. And I was lucky enough to have someone through the anesthesia side of things that was very much on board with this vision. And so I would do that. You'd be surprised with what kind of support you can get and what people will be on your side if you just show initiative and you show a desire to make things better. Now, logistically, I will say, of course, there are roadblocks. This is not a pathway that's available for IR right now. And what that means is there is no path to board certification at the moment. Now, this is something that I'm very passionate about and something I ideally, in the end, want critical care to become a subspecialty off of IR. Surprisingly, pain medicine, hospice are actually subspecialties of IR at the moment where you can actually get board certified in those. And so why not critical care? I think it's got to come from a ground level. It's got to come from trainees who are interested in pursuing this kind of pathway. And, if people see this, I think in the end, it's a no-brainer. It's a natural fit. And so make your voice heard. And it's something I think that everyone should be able to do in the future.
There was one more question. How easy has it been to become the primary as an IR? Did you have to have any conversations with colleagues to assume that role at your place?
Yeah, I'm lucky enough to practice, and Dr. V as well. I mean, we're kind of lucky enough to practice at big centers where it's already status quo that IR takes care of their patients and admits their patients. Now, whether the actual practice meets the reality is another question. And for sure, it's going to be, especially if you're working with people who are trained in kind of an older mindset, it's going to be a little legwork for you to show the benefit of becoming the primary owner of your patients, right? I mean, it's more work. It's going to require more logistics. It's going to require daily notes and rounding. But at the same time, if you can show that having these skills leads to more referrals and leads to an influx of more and interesting cases to your practice, I think over time, you're not going to have a hard time selling it to the rest of your group and to the rest of the hospital at large.
I don't know if this question's been asked before, but like at this present moment, since there's no as much involvement with the ICU, what are things some integrated IR or ESIR residents along with medical students can start doing to kind of push this forward at this moment?
Do you mean in terms of creating an ICU pathway or just?
Yeah, and also pushing it with more with the, I guess, program directors and stuff, pushing for the more ICU within the IR training.
Yeah. I mean, I kind of at the outset, I mentioned like, just ask your program director, because if you're number one, if you're an ESIR trainee like I was, at many places, you have a lot of flexibility in your final year of training. And so reach out to your MICU, your SICU, your vascular medicine folks at your hospital and ask to rotate with them. And if they think it's a good idea, the two of you can go to your program director and say, hey, look, I think this is going to be beneficial for my training. And if the drive is coming from that direction, I find it hard to believe that someone would say no to something like that. I think from a national standpoint, to drive more ICU training, I think, of course, places like the SIR need to hear that this is something that trainees want, and they also need to understand the benefit of it, right? And if the SIR gets behind something like this, then of course we can put a little bit more pressure on the individual programs, on the ACGME to say, hey, look, this needs to be codified. This needs to be incorporated as an official part of IR training around the country. This is why it's so important.
So if there's not any quick questions, I just would like to share my screen about a quick things we're doing with the ICU service line.
Sure. Let me just go through my sources, and I just want to say thanks to everyone. Please do feel free to reach out. I mean, I love hearing from you guys, especially if you have an interest in any of this stuff. So find me on Twitter or email me, whatever's easiest. Thank you all for your time.
Great talk.
So something we're doing with the ICU service line, we're trying to do like a little bit of a pilot study. It's called early exposure to the interventional trainee for the ICU management. So we're trying to look for at least 20 medical students and 20 residents, which includes ESIR and integrated, like PG 2 to 6. So this would be doing a weekend voluntary rotation, at least one per month with the ICU team. You would set up with either the MICU or SICU department where it's either agreed that they will come to during the weekend and they will agree to the structure of the rotation. And the faculty member will evaluate them and how the trainee has progressed towards the end. And also they will submit a complex case, which includes the management and workup, like the thought process, which will be evaluated by a SIR RFS faculty member. And then at the VIR annual West Coast Symposium, we're going to be using that rotational progression evaluation by the faculty member, as well as that complex case submission. Selecting winners from each level, like PGY 2, 3, 5, and 6, and also M3 and M4. So this is something, and like if anybody's interested, so this is my email, my Twitter, and we have Lindsay Masiolik, Brian Wang, who are the service line membership overall chairs. Like you can reach out to them as well, and they will be sending out info in the next couple of weeks or so. That's it.
All right, great. Now this is wonderful start to kind of the ICU initiative that we're trying to do to kind of, again, we take care of the sickest patient with end-stage heart, lung, liver, kidney, brain. And it's really critical to understand these organs well. When you're stratifying a patient, you're counseling them. Oftentimes the right thing to do is do nothing, right? Supportive therapy. And you have to own the diseases. And what I think is powerful for me and for our group is owning vascular disease and oncology disease and these different organs. We see a lot of end-stage renal, the dialysis work we have, right? We understand how weak they are. We also deal with a lot of end-stage cancers. And by knowing all these things and stratifying these patients together, we're arguably some of the best to counsel a patient on what the next strategy should be. So when I'm seeing an aneurysm patient, they have certain types of illness, whether it be liver disease or cancer or valvular or cardiac disease, I can often kind of prognosticate and guide them better than someone who only deals with one disease. And I think the ICU really helps you in that fashion as well. All right, great. Thanks everyone for participating. Thanks, Dr. Desai.
Thank you all.